Hello, my name is Dr. Paul Doghramji. I'm Senior Family Physician at Collegeville Family Practice in Collegeville, Pennsylvania, and I'm also Medical Director of Health Services at Ursinus College, also in Collegeville, Pennsylvania. I'll be speaking to you today on the practical aspects of managing patients with circadian rhythm disorders, particularly shift work disorder. Now, what's most important, of course, is we know the diagnostic criteria for shift work disorder. Shift work disorder always has either insomnia or excessive sleepiness or both. We'll talk a little bit more about insomnia and excessive sleepiness or tiredness, but one of these has to be going on, and oftentimes both will be going on, but these have to be associated with a recurring work schedule that overlaps with the usual sleep time. That is, a person is sleeping when they should be awake and they're working when they should be asleep. Second, the symptoms are associated with the shift work schedule over the course of at least 1 month. And finally, either a sleep log or, in the case of sleep laboratories where actigraphy is done, actigraphy monitoring should be going on for about 7 days or so to quantify a lot more and in more detail what's going on with the patient's wake schedule and sleep schedule and work schedule. Now, in order to come to the conclusion of shift work disorder, it's relatively easy once the patient complains that they have either insomnia or excessive sleepiness, because it immediately follows with getting a sleep history. The problem occurs, though, is that a lot of times patients don't say that they have any symptoms at all. They may have comorbidities with shift work disorder and not mention it to you, but more often than not, a patient won't really talk to the clinician about excessive sleepiness or insomnia. But when the patient looks like they're tired, or even better yet, they complain that they're tired all the time, or that they feel drowsy or sleepy, or especially if they're having trouble getting to sleep, one then gets a good sleep history. Now, a sleep history will comprise of when do you go to bed, when do you wake up, how long does it take for you to fall asleep, what happens in the middle of the night, and how do you feel throughout the day. This is a normal sleep history. Let's take an example of a person coming and saying, "Doc, I'm having trouble with my sleep." That should be pretty easy because it immediately should follow with, well, tell me your sleep situation. When do you go to bed and when do you wake up? What is it like through the night? And how do you feel throughout the day? Well, Doc, I get home at around 7 or 8 o'clock in the morning. I try to get some sleep, but I usually can't fall asleep till around 9 o'clock in the morning, and then I have to wake up at around 2 o'clock or so to do some stuff for the family. I'm kind of tired throughout the time. I'm irritable and fussy. Anyway, then I have to go to work at around 10 or 11 o'clock, and I'm really struggling then. Well, what do you mean struggling? Well, I'm tired the whole time. So already we know, just by asking a sleep history, what the patient's going through. He has shift work disorder. So let's talk about the signs and symptoms of shift work disorder. When the patient clearly has shift work disorder, that is, they are working when they should be asleep, and they are asleep when they should be working, and they feel that they have insomnia and or excessive sleepiness, we should also be asking about how much sleep time they're getting. Let's take this example of this patient that falls asleep at around 9 o'clock or so and wakes up at around 2. That's only 5 hours of sleep. That's a significant amount of sleep deprivation when we know that the average adult needs a little bit more than 8 hours of sleep. So we have to address sleep loss. Then we have to talk about the degree of sleepiness. For example, we want to ask him, well, this drowsiness that you're having, do you have any trouble when you're driving? Do you seem to nod off? Are you having any problems at work, making errors in your judgment? What kind of work do you do? And these are very important facts that one must gather when one has already diagnosed a patient with shift work disorder. Another thing that may also be very important as far as driving goes is, has there been any near-miss accidents, especially on the drive home? Now, as we discussed earlier, a sleep log may not be a bad idea, and in a sleep lab situation, actigraphy, but let's talk about sleep logs because it's more practical to the primary care provider. A sleep log is not a bad idea in some instances where the patient doesn't really have a clear-cut idea on when they go to bed, when they wake up. Let's take, for example, of a person that gets home at around 9 o'clock at night and tries to go to bed at a later time. Well, Doc, sometimes I go to bed at 11, sometimes 1. I'm not sure. What time do you wake up? Well, I don't know, weekends or weekdays? I'm not sure. Well, tell you what, why don't you do a sleep log for 1 week and write down when you go to bed, when you wake up, what's it like throughout that sleep? Do you take any naps? Also let me know when you're working on your days that you're working and what days you have off. It's also very important to understand what kind of comorbidities and what kind of effect that this shift work disorder has on the patient. Let's talk more about the effects first. First is mood issues. Is the patient anxious, irritable, like we have in this case? The patient said, yeah, doc, I'm really fussy and I'm cranky and I'm short-tempered. Are you having any trouble concentrating? Well, do you feel sad or blue? Are you unmotivated? Do you not feel like doing things? These can happen to patients with shift work disorder. And of course, we talked earlier about reduced alertness. Be particularly attentive to how this is, again, affecting the patient's specific work. Are they a police officer? Are they a healthcare provider? What is it doing to them? Any of us that have been in the healthcare field, we know that if we're working 2, 3, 4 o'clock in the morning and we're tending to patients, alertness is very, very important to make sure that we have the proper decisions made for our patients. We also talked earlier about the family situation in this particular example. What's it doing to his family life? Is he irritable and cranky with his family, with his wife, with his children? These are very important. Now, next is medical comorbidities. We should be very well aware when we understand that somebody has shift work disorder, what's going on with their medical background. Do they have cardiovascular disease? Do they have gastrointestinal disturbances? Are they having headaches? Do they have diabetes, insulin resistant, metabolic syndrome? What's their weight like? We all should be aware that chronic shift work can affect the entire physiology, going to cardiovascular, GI, central nervous system, metabolism, and on. Patients should know this and should be given the opportunity to particularly get off their shift so that these comorbidities can potentially improve because they're no longer doing shift work. So already we're talking about treatment. The best treatment for shift work disorder is not to do it. But again, the patient's medical comorbidities should be optimized when one is diagnosed with shift work disorder. And an example is a patient coming to me who works 3 days from 11 to 7 on Monday, Tuesdays, and Wednesdays, and the other 4 days she tries to lead a normal life. This patient's complaining of migraine headaches. And no matter how we optimize her eating situation, her making sure that she's well hydrated, the patient continues to suffer from migraines 2 to 3 times a week. And even when we use preventative medications, she's still getting them. An excellent treatment for her would be to get off her shift or to optimize her shift work disorder. So migraine headaches especially can be difficult to control in patients who have shift work disorder. We should also be attuned to the fact that these patients with shift work disorder may have difficulty holding on to their job. They may have absenteeism. They may have poor work performance, which can interfere with their work. And in these instances, not only is it important to optimize their shift work situation, but again, in some instances, as we've discussed earlier, we may want to encourage them to change their shift to a more traditional work situation where they work 9 to 5, so to speak. Now let's talk about shift work disorder treatments. Our most important treatment, as we said earlier, is to get the patient off their shift, but assuming that they can't, we want to do several things. We want to improve their insomnia. We want to improve their excessive sleepiness. To do so, sometimes we need to realign their rhythms and to make it as close as possible to their work situation and their wake situation. The 2 most important ways of doing so is with light and dark, and also with melatonin. With light and dark, what we want to do obviously is when we want alertness, when they are working, we want to have optimum light situation. For example, a nurse is not a good idea for the hallways to be dimly lit, and in her work situation to be dimly lit, but as bright as possible. So light should be there as much as possible during the alerting hours. But then as the patient finishes their job, let's say they're ending at around 7 o'clock in the morning, they're going to be home by 8 or 9 and are going to go right to sleep, they should immediately put on dark sunglasses on their drive home so that the light is no longer keeping them awake. And of course, when they get home, darkness is very important. It's important that we tell our patients that when they're in bed, that the drapery that they use, the curtains that they use, should block off sun 100%. Other things that are important, by the way, when they're going to sleep to help them stay asleep is to turn off the phone and make sure they tell their family, please don't interrupt me. So light therapy as well as darkness therapy can be very important. In the example we had earlier, the patient was only sleeping 5 hours and was very irritable and malfunctioning throughout the waking hours. A good advice that we can use here is scheduled naps. A patient taking about a 1 to 2 hour nap preceding going to work may be a very good idea. Let's say in this patient's case, he's going to start working at around 11 o'clock at night. He leaves for work at around 10 o'clock at night. May not be a bad idea for him to take a nap between 8 p.m. and 10 p.m. Let's be cognizant, though, that too long of a nap and erratic naps are not a good idea. It's also a good idea to advise patients to keep their non-working days, the schedules be as close as possible to their working days. Massive shifts in their wake sleep situations are also not a good idea if we want to optimize their alertness as well as optimizing their sleep situation. So these are all very important measures. Let's not forget that proper sleep hygiene is very important. We all know, for example, proper sleep hygiene means, as we discussed earlier, to make sure the bedroom is quiet and dark and conducive to sleep. Patients should also not have large meals before they go to bed, so if they come home from work, we don't want them to have a very large meal, maybe a light snack. They should minimize alcohol, minimize smoking. Exercising right before bedtime is not a good idea. These are all techniques that we all know, and we should encourage to our patients to help them to get the best sleep when they're actually getting to sleep. I mentioned earlier that melatonin is a good idea, and it's not a bad idea in certain situations where a patient has some insomnia. Let's take this case of the patient that comes in at around 8 o'clock in the morning and struggles to fall asleep at around 9 o'clock until about 9 o'clock or so. We may want to give the patient between 3 to 5 milligrams of melatonin as soon as he gets home and ask him to get into the bedroom that is, of course, conducive to sleep. That may be beneficial in helping the patient get to sleep. The problem, though, that we have with melatonin is that it may help sleep, but it does not seem to improve the alertness that we want to maximize during the wakeful periods. Some hypnotics can also be used, but keep in mind that some of the hypnotics, which predominantly are benzodiazepine receptor agonists, especially the selective ones, these medications should not be too long. For example, if one of the sedative hypnotics has an efficacy that lasts for 7 to 8 hours, but the patient only can afford to be asleep 5 hours or so, not a good idea to use that. Let's make sure that the patient's duration of action of that medication is for the duration of time the patient wants to be asleep. Let's next talk about stimulants. During the work situation, during the wake situation, we want the patient to be, of course, as alert as possible so that they could feel better, but also not make careless mistakes, like if they're driving or in their work situation. One of the easiest things to give is caffeine, but it's got to be strategic, and we also have to know that tolerance develops. What we may want to advise our patients is to get a good cup of coffee and maybe drink about a quarter cup or so every hour or two during their work situation, but making sure not to have any caffeine for 3 or 4 hours prior to stopping work so that they don't have too much on board when they come home trying to get to sleep. It can be a little bit tenuous, it can be a bit difficult to know exactly how much to give, but a lot of patients can actually do relatively well with caffeine. Again, caffeine may have some of the drawbacks or some of the side effects, GI side effects, central nervous system side effects, urinary side effects, so it may not always be the best one for our patients. Now, sometimes patients will ask us about stimulants like amphetamines. Keep in mind that amphetamines are Schedule II. They often are frowned on because these medications can develop tolerance. Again, they are scheduled substances. They can be habit-forming. They can be abused. And also, when the medication wears off, there can be a rather plummeting of one's alertness. Alerting agents can also be used. Armodafinil and modafinil are both medications that have been studied in shift work disorder and can be used in these patients who have alertness problems during their shift. So these should be given as an option to patients when they are given all of the advantages of changes in their lifestyle, all the advantages of light and dark and melatonin or even hypnotics. If these aren't working, they should be offered armodafinil or modafinil. Take the example of the patient that came in who has the insomnia as well as the alertness problem that we talked about. We would encourage the patient to take the nap like we discussed earlier. We would encourage the patient to have a lot of light during their work. And after they do so for a while, 3 to 4 weeks, the patient should come back. So follow-up. Once we tell our patients what to do to change their lifestyle, to educate them on shift work disorder, and they've done the best they can, they should come back, let's say in about 3 or 4 weeks. At that time, I will discuss with them a little bit further if there's a need for alertness with some of the alerting medications like we've talked about, like modafinil and armodafinil. And if we do so, we ask them to take the medicine about an hour or so prior to the beginning of their shift, and it should last throughout the duration of their shift. In these patients, they should be told about any side effects or problems with medications, which can be, of course, found in the product insert. But most important with modafinil and armodafinil are allergic reactions that can occur. Patients should be advised to stop the medication with any rashes, especially with flu-like symptoms. Patients should be followed on a regular basis, every 3 months or so, to be brought in because of their comorbidities that can occur with shift work disorder, which oftentimes they will have at least 1 or 2, and also to make sure that they're adhering to the treatments. Sometimes there can be changes in their shift, and we want to make sure that we accommodate them with all of our recommendations as well as medications. Keep in mind again that their comorbidities should be addressed at every one of these visits every 3 months or so, be they gastrointestinal, be they metabolic, cardiovascular, mood, etc. There are instances where the primary care provider may want to refer the patient to a sleep clinic. These are most commonly in situations where either the insomnia or excessive sleepiness isn't being remedied, and there may be other causes that are potentially considered as the underlying problem with either the insomnia or the excessive sleepiness. For example, the clinician may suspect obstructive sleep apnea or periodic limb movement disorder or other issues with sleep that may require a sleep clinician, specifically sleep testing. Certainly, if the primary care provider doesn't feel comfortable treating these excessive sleepiness situations or insomnia situations with shift work disorder, these patients can certainly be referred to a sleep clinician. But it should be kept in mind that shift work disorder is really a condition that should be diagnosed and managed by the primary care physician. So to summarize, there are many people in this country that do shift work. They're working at hours when oftentimes it overlaps with the time they should be not working or they should be asleep. And in these patients, they may present with either insomnia or tiredness. And the immediate next line of workup should be to do a sleep history. A sleep history should be very clear in demonstrating that the patient has shift work disorder, and after that, the patient should be really queried about their sleep and then to go to the comorbidities that could be going on. The primary care provider is ideally suited to identify shift work disorder and to manage it to the best of the patient's outcome.